All right, full house it looks like, but it's 7 a.m., so I'll go ahead and get started. So today we can talk a little bit about the current state of robotics and spine surgery. It's a good time to talk about it because there's a lot of events coming up dealing with robotics. Timmer's got a lab this Sunday that the residents and fellows are invited to, and this upcoming Wednesday, we're doing a lab with Medtronic and Mazor in our own lab here. So it's good to hear some of this stuff so you kind of have a background, especially for the younger guys who haven't been exposed to this kind of technology before. So that's what we'll go over. Okay, so just a quick outline. So we'll briefly talk about the history of robotics. What are the goals for robotic assisted surgery? What's the most current evidence available today about robotics and how it relates to spine surgery? We'll touch on the current generation platforms and just some tips and tricks for use of the robots if you choose to implement them or you get the chance to use it in the lab this weekend or next week. Okay, so where does the word robot come from? So it actually comes from the Czech word robota, which means forced labor, and it was first introduced in this 1921 science fiction play, where basically robots were created by humanity in order to do tasks that were deemed unfit for people, or for tasks that people didn't want to do. So that's where the whole idea came from. You can see the robots here have turned on their human masters at some point in the play. So it gets a little dark, but I don't think we're there yet. Actual robotics in history started out in 1959. This is when the first industrial robotic arm prototype was installed in a General Motors plant. Robotic arms were initially used for, or recognized that they could be used in industry to complete tasks that were deemed maybe too unsafe, or tasks that could be stereotyped and increase productivity. By 1961, we had the first mass-produced robotic arm. And then in 1969, we have the first General Motors plant to implement a large number of robotic arms, allowing the plant to produce 110 cars per hour, which is more than double the rate of any automotive plant in the world at that time. So clearly, at that point, everybody else needed to get on board and follow suit, or else they would drown because they wouldn't be able to compete. Down here, there's a couple photos. This is actually from the Tonight Show with Johnny Carlson in the mid-60s. They brought the robot arm onto the scene, and they had it doing a bunch of different parlor tricks like pouring beers and stuff like that. And fast forward to today, this is a Tesla plant where the vast majority of production is done by robots. So to first understand robots in surgery or industry or whatever, we have to understand the type of robotic systems that there are. First, there's master-slave systems, and these systems are entirely dependent on surgeon activity. The most obvious example of a master-slave system would be the Da Vinci robot, where you're directly controlling the robotic arms to complete a task. Then active systems, which work autonomously perform a pre-programmed task. This would be like a robotic arm in a factory doing something stereotyped. And then finally, what's most applicable to us is semi-active or passive systems, where this requires a surgeon-driven element to ultimately complete a pre-programmed task. So we've called these cobot surgeries in the past and in the literature, and this is basically what we have to deal with in terms of spine surgery today. In general, you could say that these are more of guidance systems than anything else. Robots in surgery in general, in 1993, the ASOP, and then later on the Zeus, and then finally Da Vinci were introduced into general surgery. This represents the progression of general surgery robotics. They started out basically just being a voice-controlled endoscope, freeing up the surgeon's other arm to have two instrument arms, to today where we have robots with 3D stereoscopic optics, 4 arms, and 7 degrees of freedom. When you're doing laparoscopy, you're limited by the 2D optics, and also 4 degrees of freedom through a fixed entry point. So you don't have the ability to use a wrist per se in an insufflated abdomen, but that's all been changed over the years. Like I said, Da Vinci is kind of the main player in this term. It was the master-slave system. It was first FDA approved in 2000. They basically have the monopoly on the general surgery robotics market. The endo wrist, as I described, allows you to have extra degrees of freedom inside the abdomen. And today we're seeing it used for virtually all GI surgeries, many cardiovascular surgeries, some bariatric surgeries, urologic surgeries, and gynecologic surgeries. This is just a quick look at the rate of growth in robotics, in the Da Vinci specifically in these fields over the past 10 years till 2018. There's been a precipitous increase in use in general surgery and urology and gynecology. And actually, the vast majority of prostatectomies done today are done robotically. Actually, though, interestingly enough, the first robot implemented in surgery, I mean, this was a kind of a proof of concept, but it was actually neurosurgery. This is an industrial robotic arm that was repurposed in order to do stereotactic brain biopsy. And so, you know, this is kind of the first introduction. This is very similar to what we're doing today with the ROSA robot for brain biopsies and lead placement. But back to what's important. So spine surgery and robotics. So this is the progression of where we are today. So this all started in 2004 with Mazora's Spine Assist robot. Their second generation robot, the Renaissance, was released 7 years later in 2011. Then we have the Mazor X, which many of us are familiar with as we have one at UMH. And then in the same year, Globus came out with their own robot, Excelsis GPS, which is very similar with navigation. And then a year later, when Medtronic bought out Mazor, they implemented stealth technology. Now we have a Mazor X with real-time navigation. ROSA 1 is very similar. It's the ROSA, but with the spine package, and it basically does the same thing. And these systems all, you know, over the past years have been targeted towards just placement of pedicle screws. They all basically do the same thing, but they've become a little more sophisticated as the years have gone by. And why is that? I mean, there's a lot of potential for growth that's been recognized in the market. And so a lot of money is being pumped into this. So the global spinal robotics market was valued at $75 million in 2017, and we're expected to reach $320 million by 2026. So almost paralleling what's going on with what has happened with general surgery, one could assume that robotics and spine is going to pick up and continue increasing use for one reason or another. So now we can talk a little bit about, you know, now we're done with the history, you know, what are the goals of robotics in spine surgery? What are we trying to get out of them? In general, things that we want to do, we want to eliminate unwanted motion. Along the same line, we want to improve manual dexterity. We want to facilitate these minimally invasive operations, and we want to allow remote surgery. Remote surgery is actually something that kind of started this in the first place. There's a lot of money pumped into robotics initially by DARPA and NASA to study whether or not you could have a robot that could perform surgery either in space or on the battlefield. And so that's where this all kind of came about. And then in the end, you know, where we're at today, more realistically, we want to achieve all these goals, but at the same time improve or at least have equivalent outcomes compared to open surgery and be cost effective. Spine surgery specifically is a little different. So classically, these robots have been focused on instrumentation placement, so pedicle screws. The idea is to increase the accuracy of pedicle screw placement, to decrease complication rates, increase patient safety, and then improve patient outcomes as a result. So that's kind of where everything is centered. But kind of like I alluded to, we want to decrease intraoperative and postoperative complications. Postoperative may be even more important as cost becomes more important in medicine today. And then other things to take into account. Radiation exposure is a big issue, particularly if you're placing screws under fluoroscopy. There is exposure to the patient, there's exposure to the surgeon and the OR staff. With robotic placement, the patient is still exposed to at least one CT scan, which is used for registration, but that obviously isn't putting the surgeon or the OR staff at risk either, who are there day in and day out doing the same thing. And then similar to general surgery, we want to improve ergonomics. This could be thought of as if you want to put screws in the lateral position, it can be a little cumbersome. If you have the robot there, helping you with it, it does take some of the cognitive workload out of doing those kind of operations. So that can be done that way as well. And we've seen that in the literature and technical notes as well. And then in the end, like I said, the whole idea is to improve patient outcomes. Okay, so the most important thing probably is to talk about the current evidence of robotics, where it's been, where it is right now. There's been a lot of interest in robotics recently in the past decade, and there's a lot of literature coming out now. A lot of the literature is limited and biased because it's funded by industry, but it's important to be aware of all these things and to see what exactly is out there. So why is that all important? Why do we need to talk about evidence? Well, like I kind of mentioned before, there's, at least with general surgery, there's controversy as to whether robotic assisted surgery justifies the high cost. For the Da Vinci in particular, it costs $2 million per unit. And robotic surgery in general is about $3,000 to $6,000 more than a conventional laparoscopic procedure. So you'd say, okay, well, that's fine. As long as we're having better outcomes and patients are doing better, then you can justify that cost. But, are we really justifying that cost? And, the example is robotic prostatectomy. I mean, more than 90% of prostatectomies are being performed robotically today. That being said, there's controversy as to whether it makes any sense. I mean, there are benefits to be more minimally invasive. There's decreased blood loss, decreased operative complications, decreased length of stay, better quality of life at 6 weeks. But there is level 1 evidence that shows that functional and quality of life outcomes are no different at 24 months. So maybe it improves outcomes in the short term, but not at the long term. And whether or not that affects the overall cost is really kind of the main question. Is it worth it? And a lot of these cost studies, aren't there aren't a lot of cost studies, and particularly in spine surgery, there's basically none. So that's something to think about. So going back to robotics and kind of paralleling what the goals of robotics are, the first thing is accuracy. So like I said, the majority of robotics literature has focused on the accuracy of pedicle screw placement. Typically, what papers have done is they've used the Gertzfein and Robbins scale to grade accuracy. This is a scale that's accuracy is graded on a postoperative CT scan, looking at the degree of breach. So grade A would be no breach, a grade B would be a breach less than 2 millimeters, C 2 to 4 millimeters, and D 4 to 6 millimeters. Now, what's typically quoted in the literature is that a clinically acceptable screw would be a Gertzfein-Robbins grade A or grade B. And and what we see in the literature is that more than in general, Gertzfein-Robbins A and B is seen in of greater than 90% is seen in the majority of studies that are available. So most studies are showing a very high accuracy of robotic guided placement of instrumentation. And this is predicated on if you're using the robot, correctly the way it's intended. That's kind of the big disclaimer. Yes, sir.
Can I ask a question, Alan Levy?
Yeah.
That classification system to me seems a little imperfect. I mean, like you could have a lateral breach of less than 2 millimeters and it's meaningless. You could even have a lateral breach of 4 millimeters and it's meaningless. But if you have a medial breach at the L5 pedicle of 1.8 millimeters, I mean, that could be significant and not acceptable. Is there the Gertzbain-Leonakis augmented scale.
It's a good point, and I thought about that, and it doesn't really. I don't think it differentiates on the laterality of the breech. And you're right. I mean, if you're breached 2 millimeters medially, it's probably going to stim low when you stim the screws, and it's going to have a problem. And then here where we do that, we'd probably replace it, and then we'd call that clinically unacceptable. It's definitely not perfect, and nobody's really talked about that in these papers. There's another classification, the Ravi classification, which is basically the same thing. I don't know why the two names are different, but you're right that is imperfect, and they don't go
from a historical perspective. Just so you know, that Dr. Gertzbain was a orthopedic spine surgeon at Sunnybrook Hospital in Toronto. Probably retired maybe about 20 years ago. I don't know who Robbins is.
Okay. And I'll talk a little bit about some of these papers that show, and we can look and see exactly which ones are A, how much is A and B, and the majority is A, but we'll see right now. There are some studies that do quote that there's higher accuracy, certainly higher accuracy with robotic guided placement than freehand, but also some that show that it has been higher than CT navigation as well. And so this recent systematic review by Dr. Park and colleagues basically looked at 25 studies, majority Mazor studies, mostly retrospective, a couple prospective, and a couple randomized controlled trials to see, where we're at. They looked at a variety of different things, and what they found is that accuracy is what we said before is suggested to be superior to conventional screw placement, so more than 90% in most studies, but they weren't really able to conclude too much else. There was wide variability in the fluoro time during cases, anywhere from 1 second to 34 seconds. I don't know where that would come from. I do know that some people who actually use the robot will actually, particularly if doing like percutaneous screws, will actually use the robot and use fluoro at the same time, which doesn't really make any sense. And I mean, obviously it implies that, there is concern as to whether it, is doing what it's supposed to. So maybe that's part of it. It's not documented in papers what exactly that kind of technique is. And in terms of the learning curve, there's certainly a learning curve, but it's hard to define. And they also go over some reasons for robot failure, software registration failure. We've seen some of these things at using the robot, as well as skiving and soft tissue pressure on the arm changing trajectory. That's the main one. And I'll talk about this a little bit later, but the robotic arm really does not do well in tight corridors. It's good for perk. It's good for wide open exposures, but for limited exposures, like if we were, for how we do like a 1 or 2 level open TLIF or something like that, it doesn't work quite well, particularly in large patients, because any tension from the soft tissue on the robotic arm will throw it off. But, the question then also is, this is fine. Like we have these studies now that are looking at all these robots, but all these robots are, technically retired. The 24 studies in this paper were all either spine assist or Renaissance. And the question is, what about the current ones? So I think of these robots kind of as like they're almost like iPhones. There's a new one every year, and they've all got something new bells and whistles. They all kind of do the same thing, but can you really generalize old studies to these new technologies as they're coming out? I think right now we're at a place where the current systems will be with us for a long time, and we'll just kind of have add-ons, additions for different kinds of use. But there's a huge difference if you just look at the robot, look at like the Mazor X Stealth compared to like the spine assist. I mean, just looking at the two systems, you have to wonder, are these really comparable? So what about research regarding the current generation of robots? And there's really not that much. There's 11 studies in the literature right now that primarily report on accuracy of the current robotic systems. This would be the Mazor-X, including the Stealth Edition, the Globus Excelsis GPS, and the Rosa robot. Now, what these have shown is, again, high accuracy, 97.3% to 100%. These are the studies that are currently available. And you can see that they're kind of split between Globus and Medtronic here. There's actually only one study, and it's actually just a technical note that looks at the Stealth Edition. The rest are Mazor-X. Technically, that's one generation behind, but I included it because they have the longest track record, and technically the Mazor-X itself is a third generation system. So if you look at these as a whole, this is what we have. I mean, I highlighted this here. I mean, the sample sizes are not large. I mean, the greatest one has 101 patients, 600 something screws placed, but the rest are, in general, a lot less. Accuracy is here, and this is typically the A and B would be Gertzbein Robbins. 1 and 2 is Ravi. They're basically the same thing. So if we just look at A, we see 100%, 99. This one didn't. The second one didn't specify. 100%, 99.5%, 98.1%. Here, this study right here is a little lower. So 86% grade A, 11% grade B. So like Dr. Levy said, there could be some issues there that aren't reported. And then similarly down here as well, 86.7%. But then some of the other ones have higher rates. I mean, close to 100%. Now, you have to take all this kind of with a grain of salt as well. I mean, but this is basically what's being reported. So just looking at this, I would say that the accuracy is high, but we kind of already know that.
Hey, did they take out
Yes,
the
sir.
learning curve on all those papers? The first 20 cases?
I don't think so. No. Sorry. So it's not mentioned in many of them. They say it's consecutive. So you would imagine that means that they wouldn't have left out cases, but that specific thing about whether we did so many and then we started from here once we had our flow, that's not really specified. So it's a good question.
I'm sure you'll talk about that learning curve aspects and adoption, because obviously all of these technologies require that investment. Right.
Yeah. I mean, and actually Timmer wrote a paper about this when we had the initial, it was either Spine Assist or Renaissance. And I don't have a specific slide about it in this presentation. I talked about it the last time. But what most there's a few studies that look at learning curve, and most are saying up to 30 cases till you hit your flow. And this is primarily as a result of kind of everybody getting to understand, how the robot works, this and that. And there are some idiosyncrasies that I'll talk about, and also even having the staff on board to have the workflow running smoothly, because otherwise, in some cases, the operative times can be longer with the robot than without, and other times it's shorter, and that's been attributed to learning curve changes. So that's basically where that is. Okay, so with respect to implant-related complication rates, so of those 11 studies I just mentioned, 6 of them mentioned this, and none of them had a quote-unquote implant-related complication, i.e. An issue during surgery, a vascular or neurologic event, or a post-operative return to the operating room for like a new onset radiculopathy or something like that, or a screw that was found to be completely misplaced. These are those. I kind of updated this slide here. I mean, some of them included, some of them don't. Again, these papers are primarily accuracy based, and this is kind of like a one-line sort of thing. There were no implant-related complications in the short term as a result of these cases. In terms of the radiation burden, I mean, if we're using fluoroscopy to place screws, I mean, it's almost common sense that a robotic system would obviously involve less fluoroscopy in the operating room than using fluoro-guided placement. I mean, that's kind of a given. There have been several studies that report significant reductions in radiation exposure compared to fluoro guidance. And like I said, I think that's a given. I'll talk about this. This most recent study, MIS Refresh, reported an 80% less fluoro time per screw for robotic guidance compared to fluoroscopic guidance. And MIS Refresh just isn't published before print right now within the last like 2 or 3 weeks, which is kind of a landmark study in terms of robotics, because it's the first prospective study, multi-center. It was partially randomized. Some of the sites were randomized, but not all of them, comparing minimally invasive robotic and fluoroscopic guided lumbar fusions. And Dr. Wang is a senior author on this paper. Basically it looked at 374 robotic cases versus 111 fluoro-guided cases, with the primary endpoints being complications and revisions at 1 year. And so what they found was that there was more or less a 5.8 times lower risk of surgical complications associated with robotic guidance, and 11 times lower risk of revision surgery associated with robotic guidance. Now, this is within 1 year, and complications include basically anything, any adverse event that occurred after surgery. So in this, we're including things like medical complications, screw-related complications, hardware-related complications, surgical site infections, everything all together. So this would be the first study that shows that there's a lower complication rate associated with robotic surgery compared to non-robotic. And like I said, an 80% reduction in fluoroscopic time. So this study kind of paves the way for more research, multi-center studies, prospective studies looking at this, because you can say, okay, this is pretty significant. So the question is, why is that? Why is the surgical complication rate lower? Is it because, by using the robot, we kind of reduce the cognitive workload of putting the screws in, so you can focus on the decompression, so things go faster, so there's less hands in the wound, less stuff going in, so maybe the infection rate is lower. There's a lot of questions that remain to be answered. And I would say that of the complications that occurred when we looked at this data retrospectively in a subgroup analysis, most of the complications after surgery are medical complications, including things like surgical, non-surgical site infections, but anything kind of UTIs, cardiac issues, all that kind of stuff was the primary group. And then as well, pain-related complications like recurrent or increased pain after surgery that wouldn't be otherwise expected was much more common in the freehand group compared to the robotic group. And then continuing on that note, this systematic review meta-analysis came out in World Neurosurgery before MIS Refresh, and they basically were comparing robotic, navigated, and freehand thoracolumbar pedicle screw placement, and they really were unable to form any conclusions regarding comparing robotics to either navigation or freehand placement because of the total lack of robotic data. So this basically shows that there was basically a dearth of information available, and now we're starting to come out with studies that are starting to show that it may potentially reduce complication rates. Obviously, this is going to require a lot more research and understanding why exactly that is, but the available literature is very limited. In terms of revision surgeries, those 11 papers that I discussed before, a few of them also mentioned whether or not any implant-related revisions occurred, i.e. An unrecognized malposition screw resulting in a new onset radiculopathy. There were 5 papers that reported that, and the ones that did report it said there were none. We don't know about these other papers, so it's hard to draw any conclusions from this. And then what I think is probably the most important thing moving forward with spine, not just robotics, but spine surgery in general, is the concept of patient-reported outcome measures. So as I think as reimbursement starts moving towards a more value and patient satisfaction-based model in the future, this is going to become very important. And this is kind of what it's all about in the end. Are people doing better as a result of what we're doing to them? And there hasn't been a lot of research into this. There have been 3 papers that have talked about it in terms of robotics specifically, that then were combined into this systematic review. And basically each paper on their own show that while VAS and ODI scores improve following surgery for either robotic or non-robotic, which would be expected, there is no difference between the two. And so that then brings up the question, is it really worth it to do it if people are feeling the same either way between robotic and non-robotic guided surgeries? So obviously there needs to be more research into this with long follow-up periods, because follow-up periods have typically been shorter, but this is kind of where I think we need to focus on. And this alone at this point shows that there may not be a difference in patient-reported outcomes. So overall, what's the consensus? So most studies say that there may be, acknowledge that there are probably potential benefits of robotic-assisted surgery, but at this point, the literature is limited and heterogeneous. I mean, those limitations, like I discussed, include most studies being retrospective in nature, small sample sizes, studies using quote unquote retired systems, and then finally this thing about industry funded research. It's hard to tease it out, but you would imagine a lot of the literature out there, is biased in some way, particularly if they're using the same robotic system, et cetera, which is usually the case, because you can't really afford to have so many robots at one center. So it's really something we have to think about critically when we're looking at these papers, because there may be a slight. And right now we just don't know. And what we see is, it's great with MIS refresh, because that's kind of the first prospective paper that showed that there are benefits of robotic guided surgery over freehand or fluoroscopic guided, but there needs to be more high quality research. So this is basically what I just said. So in the future, we need more prospective comparative studies. We need to focus on preoperative and postoperative outcome measures, how patients are doing, how they perceive themselves to be doing, things like VAS and ODI, and then cost modeling to see if it really works to see if it's really worth it. I would imagine it's a large proposition to have a hospital system purchase one of these robots and then go through, all the time and more costs with disposables, training, et cetera, to put them into place. So, we need to know if it's worth it or not in the long run from a finance point of view. Okay. So that's basically where we stand with that. So this will be more for kind of the junior residents who haven't been, exposed to this. We talk about the robots, but what are they? So here they are. These are the 3 that are currently available. They all look exactly the same. They all basically do the same thing, but there are salient differences between them. In the top left, this is the Mazor X Stealth Edition. This is the one that we have here. Over on the right, this is the Globus Excelsius GPS. And then at the bottom is the ROSA, which most people are familiar with from the cranial work. So they're all basically rigid guidance systems. The Mazor X Stealth Edition, it fixates itself to the operating table, whereas the Globus and ROSA robots basically are on wheels and just kind of pull up to the table. They all need to be rigidly affixed to the patient. This is usually done by placing a Shands pin in the PSIS. And they all either require a preoperative thin cut CT or intraoperative O-arm spin to register the patient's anatomy. The only one I've used in practice is the Stealth Edition. I've used the Excelsius in the lab, and the ROSA I haven't used for spine. ROSA is actually, I think it's only used at, there's only 6 hospitals that are using the ROSA for spine right now. So, obviously it's the one that's been least adopted in terms of spine. It's the most new. We'll see how it goes. It's floor mounted, like I said, and it has all these little things that it can do. The things going for the Mazor is that it obviously has the longest track record in this field. I mean, the Mazor system is being the one that started it. So it has that history behind it. It's been coupled now with stealth navigation, which, as we know, is basically one of the premier navigation systems. And they have a pretty good planning software, which I think is going to be more and more widespread used as the years go by. The Globus robot, the benefits of it is that it's a very rigid robotic arm. You could literally do pull-ups on off the robotic arm, and the robot would be okay. If you did that on the Mazor, the arm would fall off. So that's one thing. I mean, that's important because when you're placing these screws, that means it's easier to redirect the Mazor in an appropriate way than it would be for the Globus. The Globus is floor mounted, so potentially there's less moving parts. They're the one company that's now started integrating their robotic system for MIS, interbody fusions. You can actually use the robotic arm to hold your tube in place while you do your discectomy. I'll show a picture of that. They've got some other bells and whistles. And one thing that I like is it actually has 2 reference frames, so that understand where each other are in space. So that's just one extra safety measure, that if the patient moves or whatever, you know that you've lost your registration.
Jason, can I make a comment there? Because I think it's important. I mean, I understand that a lot of that is, what you're saying is absolutely true. But I think that there is this false pretense that rigidity is always superior. And it's nothing against or for the Globus versus the Mazor X robot or the Medtronic robot, because they're different philosophies. And I will tell you that you're right that the Globus robot arm is much more rigid. However, if you look in the history of what's happened, the truly errant screw placements, the ones where a screw is like in the kidney, have not happened with the Mazor arm because it's sensitive. It's just like, it's like a lot of things. You give up one thing for another, right? And so the true outlier errors, I'm not talking about a Gertz being grade 3 breach. I'm talking about a screw that's 7 inches away from where you planned it, have occurred more with the rigid arms. Obviously this is a lot of, as you mentioned, a lot of stuff in progress, but I just wanted to make that comment because I think that it's a common marketing thing that's said, but the actual clinical practice is a little bit different.
So that's a really good comment, and that's kind of like the elephant in the room. And we know that there have been horrible screw malpositions with the robots, with certain companies like you mentioned, but that's not documented anywhere in the literature. So we've all heard about it, but it's not in the literature, which also then should make us a little bit more, I don't want to say skeptical of the technology, but it goes back to, understanding that these are tools. They can certainly make errors, and there may be other interests at play with, maybe with the literature or whatever. I mean, this also speaks then for the Mazor. Like I said, it really does have the longest track record with this, and with stealth as well. There's something, you can't really replace experience, is basically what I'm trying to say. So that's totally true, and it's definitely something we have to be aware of.
Well, Jason, you're being very humble, so you are eventually going to get to all the data that you've been doing, leading these conglomerations of groups and study groups on robotics, right? You'll eventually get to that.
I was going to touch about it a little bit. I wasn't going to talk about it too much because we haven't published yet, but I can discuss it. Yep. Okay. So basically, let's see here. Okay, so beyond pedicles, basically beyond pedicle. So, this just kind of then talks about, the planning software, is pretty good. So we've used the robot to do different things. We wrote this technical note, basically utilizing the planning software to plan trajectories towards Camden's triangle, in order to do endoscopic robotic MIST lift. So we've done that. That's an operative neurosurgery, and there's going to be other applications for this in the future. This is an example of what people are considering now to do now. Using the tubular retractor system for MIST lift, you can use the robotic arm to hold it. That's another application. This just shows that, there's more that can be done, just not just including pedicle screws. Okay, so I'm going to talk a little bit about some tips and tricks, what I've learned personally and what we have on the horizon. I didn't include it in a discrete slide because we haven't quite published yet, but there's a lot of stuff going on with MIS refresh. That was a treasure trove of data, and but they were just looking at complication and revision rates. Like I said, what's really important is understanding, what complications are there and why. So, with Dr. Wang, we've kind of put together a team to look into this in a little more granular detail. And what we found is that the subdivided complication rates into medical, surgical, et cetera, we find that the majority of the complications are related either to medical complications. This could be things as simple as the UTI, a cardiac event, something like that, but mostly minor medical complications, and also pain-related complications afterwards. We published another paper where we looked at the fluoro in general, which reaffirmed what MIS Refresh recently published, that the radiation exposure is significantly less in robotic guided instrumentation compared to fluoroscopic guided, which we understand. And then most recently, we put together a group. It doesn't have a specific name, but I call it the Spinal Robotics Study Group. We're basically a multi-center group. We're beginning to look at building a database of robotic surgery for the current generation of robotic systems, focusing on the Mazor X and Mazor X Stealth Edition. And where we are right now is that we've put together a database of 5,000 over 1,000 surgeries with over 5,000 screws placed. And we have all the data from the robots, including VAS, ODI outcomes. And our first step was to look at this data retrospectively and look at complication and revision rates. And what we have found is that they're quite low. In fact, out of 5,000 screws placed, there were only 5 cases of a unrecognized malposition screw at the time of surgery requiring a return to the OR on the same index admission for replacement. We also found that the accuracy was very high, close to 99%, and the postoperative revision rates and readmission rates within 90 days were less than 1% for this group. So I didn't put it in here because it's not published yet. We've submitted it to JNS Spine. We're going to see how it goes, but it's very exciting. And then just some general tips and tricks. There's certainly a learning curve, like we discussed already. This is kind of soft touch surgery in a way. Open cases really do require a larger skin incision to get the appropriate, to get the medialized trajectory you want. If it's a very small skin incision, you have to compensate for that by using screws that are more straight on. There's a potential for skive and shift. Skive is when the instrument slips off, a tangential surface that it's met. Like if you're right on the lateral border of the facet and the screw slips off, that's a skive. That can happen. That kind of has to be understood by you, either by looking at it or feeling it. And then shift is when the actual spine moves, and that throws off your registration. So that's kind of an issue with these new navigated systems, because one, the robot is off, but then the navigation is showing you're someplace where you're not either, and you can be tricked into thinking that it's accurate where it's not. So these are things that have to be watched out for. We've already talked about radiation exposure, and the marketing potential for these things is very significant and can't really be ignored. No. Okay. So we see all these billboards like driving down I-95 about everything MIS, MIS robotic surgery, etc. So it's definitely a big thing. And we talked about this already there's pros and cons to robotic surgery. We know that screw placement appears to be safe. There is a decreased radiation burden. And, in the end, what I think is most important is this may have the potential to increase reproducibility and standardization of cases. If you know that you're going to do a case and you're confident that you're going to do a case in, a certain time period because you have this kind of assistance, then that can allow you to schedule more cases or just organize your practice better. But there are cons. Cost is a major one, potentially increased procedural time, at least during the learning curve, and risking an over-reliance on technology, kind of what goes on with navigation. If you learn just how to navigate in residency or whatever, you could become reliant on that. And it's important to understand the anatomy as well. So we can't just rely on these these technologies as trainees. Okay, that's basically it. I talked about all this already. Any other questions? Okay, thank you guys very much.
Hey, you guys can hear me?
Yes, I can hear you.
Excellent. Let me just give me a second to share my screen.
Great, looks good.
Perfect. Okay, excellent. All right. Hey, everyone. I'm sure most of you all know who I am. I'm Evan Luther. I'm a PGY5 here at the University of Miami. And this morning, I'm going to be talking to you guys a little bit about some of my research interests and background of the research I've been working on while here as a resident, which focuses on the technology of optical coherence tomography. So just as a overview, we're going to kind of talk about the principles behind the technology of OCT, its current medical applications, the available data in neurosurgery, and then the future applications in neurosurgery, which is where my interests kind of lie. So just a brief background on my history. I was a biomedical engineer in college. I worked in Dr. James Tunnell's lab as an undergraduate, and there we primarily were performing non-invasive evaluation of various skin cancers. The hope was to use machine learning to develop a device that could optically biopsy various skin lesions just based on their spectral profiles. I kind of took that and then applied it in medical school in Dr. Mark Feldman's lab, where I started using OCT to evaluate optical properties of various tissue types within atheromatous plaques, hopefully in an effort to diagnose and differentiate those plaques at higher risk of rupture. So then that was kind of applied when I came to residency here at UM with the help of Dr. Stark. We recently received a grant from the SNIS to use OCT technology here in the endovascular suite to evaluate aneurysm occlusion over time. So as Isaac Newton said, if I have seen further than others, it's by standing upon the shoulders of giants. So thank you to everyone who has helped me get to where I am today, especially Dr. Stark. Before I start, I also I wanted to kind of go over this with everyone because I certainly felt incredibly discouraged throughout my last 5 years as a resident, applying to multiple grants and not receiving any of them. So, this is just an example of the years of all the grants that I've applied to in the last 4.5 years. Keeps going, and there we go. That's the only green one. So, I think the reason why I think this is so important is because resilience is really key, especially in neurosurgery and in research itself. I remember even this year, and I'm sure Kat can attest to this, that I told myself if I didn't get this grant, that I was done submitting grants. I would just stop altogether. I'm done with it. And then I got an email at 6:30 in the morning telling me that I'd received this grant. And I remember throughout this whole process, and Dr. Levy had reached out to me and said, listen, if you have a great idea, someone will eventually fund it. And I think, for me, this persistence was key to helping refine the ideas. And then that turned into, something that became worth funding. So I think if you're a junior resident and you're sitting here listening to this talk, or not listening to this talk, but you think you have a good idea, in research, is that you have to just continue to be resilient. So with that being said, we'll start with talking about kind of the basic technology of OCT. So optical coherence tomography is a technology that uses near infrared laser light to evaluate changes in a sample over a cross-sectional area. So it's not that similar to the lasers used in Austin Powers, but it is a laser. So I think the first and most important principle to understand in the technology of OCT is the concept of interference. So I think this is, this image here is a really good example of what interference looks like in terms of waves. So you think of it as kind of the additive or diminutive effect of two waves as they intersect one another. So you can see here, although this is an example in a water wave, that these two waves created by this guy create this distinct pattern here, where they have where they intersect. They create areas of both what we call constructive interference and then destructive interference. So, and as you all remember, with laser light or any light, those light particles or photons can behave like waves as well. So this is kind of just a discussion or an evaluation of what it looks like to have constructive or destructive interference. Like you can imagine in that pattern, in that water, in the previous example, total constructive interference occurs when one peak of one wave merges with the peak of another to construct a larger amplitude wave. And in that same vein, total destructive interference occurs when the peak of one wave merges with the valley of another, and then they cancel each other out. So this is just kind of an example of this additive or diminutive effect based on the interactions of the waves. So I think this is another good example and kind of really the crux of how OCT works. So obviously in nature, we don't really have total destructive or constructive interference because many times light waves are not, totally in phase or out of phase of one another. So this kind of diagram here demonstrates the true principles of OCT regarding the interference patterns and how this can be utilized to determine a depth of a sample or variations within the depth of a sample. So if you think of this, in terms of an incident light on a surface, there's always some reflectance and some absorption of the light. So the reflected light immediately kind of bounces off the surface of whatever you're imaging or evaluating, but there's always going to be some that penetrates the sample and then gets reflected back later on. So this difference, this interference, or so this change in phase of the waves based on the depth that they've traveled causes a distinct interference pattern. So if we can evaluate that interference pattern, then we can potentially find out how thick a sample is or find out different layers within a sample. So it's really basically how the penetration of the light creates a more or less reflectance pattern in the sample itself. So you can see that, obviously if you evaluate this interference pattern of these incident beams on a surface, it can create some images that are analogous to ultrasound, right? It's based on penetration depth and reflectance of a wave, right? Same like ultrasound, except ultrasound uses, as you can figure, ultrasonic waves. So when this is applied to tissues, you can imagine, just like in this image, that it can easily identify various boundaries within the tissues with relatively high resolution because of the very minute changes in the interference patterns of a laser. So with that being said, you can also imagine that if you deployed something like this within a catheter, then you could image a diseased vessel, such as the one kind of depicted here. And then with a little math, you can produce images that look like this. So this is just an example in cardiology where you can see here, they're imaging using OCT to image through a coronary stent. You can see here that the distal edges and the proximal edges of the stent are able to be evaluated, as well as the midsection, and then they're able to evaluate the cross-sectional area and kind of geometry of the stent down the length of it. So I think it's also important to discuss that OCT is not only a high resolution imaging system, but it also has the unique ability to obtain spectral content of the tissues being imaged. And what that means is that, you know, all materials have a basic absorption and reflectance spectrum that all of them carry. And so OCT is fairly good at not only identifying the morphology of whatever tissue you're imaging, but also tissue content based on the reflectance and absorption of that tissue. So the example here that I'm providing is just showing the identification of lipid-rich versus platelet-rich plaques. This paper here, when compared to the histologic evaluation of these vessels, showed that they could do this with 90% accuracy, identifying, you know, what type of tissue was within each plaque. And furthermore, now people are even using it to create algorithms to automatically detect different cellular content within the plaques using OCT. So you can see, you know, I mean, this technology has relatively tremendous potential. But I think the next step is to really talk about its current uses in medicine in general. So it can't quite revive patients yet, but it definitely has some pretty awesome applications. And I think the first and most widely used is in ophthalmology. So you can see here, this is kind of an OCT system where a patient is sitting down, you know, having his retina imaged just, you know, by looking into a small, like, microscopic lens. And the important thing here is that it kind of provides basically an in vivo radiographic biopsy without causing any retinal damage or requiring any contrast or staining. You know, it provides these cross-sectional views with high resolution and allows for detailed differentiation of structures. And the sensitivity is so high that they can, you know, image the vitreoretinal junction with almost 10 micron resolution. And it can even, you know, differentiate between the retinal pigment epithelium and the nerve fiber layer. And furthermore, you know, new advancements have allowed for 3D renderings of the retina. So you can see, you know, you can see images just like this. So other applications, not just in ophthalmology, but in surgical oncology as well. It's been used intraoperatively for the real-time evaluation of metastasis to lymph nodes in patients with cancer because of its really innate ability to identify tumor margins. This image here, image A, just demonstrates this capability. It shows a tumor boundary between known adenocarcinoma and the surrounding normal host tissue. B here on the bottom shows progression from normal tissue to an adenoma to an intraepithelial neoplasia in the colon. And then C here demonstrates actually the use of OCT when monitoring tumor viability after interventions. So again, this is just another example of its uses in oncology. So, you know, this is a publication in which they used OCT intraoperatively during a radical mastectomy to evaluate the lymph nodes prior to excision. So, you know, images A and C are these OCT images of the lymph nodes. So, you know, obviously this technology has relatively huge implications in the oncology world if it can prevent the need for extensive lymph node dissections when you can identify which lymph nodes are actually involved intraoperatively. But then the question is, why should we care as neurosurgeons? So, you know, it's been used in surgical neuro-oncology as an adjunct during biopsies to help detect vessels that are not obviously seen on MRI. This image here is just an example of a 3D volume rendered MRI, which showing the needle trajectory of a patient undergoing a biopsy. This small green rectangle here indicates the region in which they placed the OCT catheter and the scanning that was performed. And then this inset here on the bottom shows the actual OCT imaging with multiple delineated vessels indicated by red rectangles. So they kind of use this as an ability to evaluate any neighboring vessels during the biopsy to plan where their cutting window of the biopsy needle would be. So furthermore, in animal studies, they've even used it to detect tumor margins in animal brain tumor models. So you can see here, image A demonstrates this tumor boundary prior to treatment, and then E indicates this residual tumor following surgery that then was subsequently confirmed on histology. So again, this intraoperative use, of guidance to identify tissue boundaries it provides kind of real-time feedback to surgeons during resections and can potentially revolutionize the way we perform, any type of surgeries. So getting back to cardiology, OCT was FDA approved in humans for percutaneous coronary interventions in 2012. It provided cardiologists with a detailed view of vessel lumen geometry, stent apposition, expansion, and restenosis that was never seen before. It allowed also the quantification of thin fibrous caps and lipid-laden macrophages within plaques, which helped cardiologists determine the potential risk of rupture for these lesions. So this here is just an image of an angiogram of the right posterior descending artery in A, and then B shows it after balloon angioplasty. C is an intravascular ultrasound, which is what was used prior to the use of OCT, not demonstrating any obvious pathology within the vessel. But then D here is the same vessel being imaged with OCT and demonstrates multiple tears within the intima following balloon angioplasty that were not seen on intravascular ultrasound alone. And then here on the right, this is just an image demonstrating this thin cap fibroathoroma that was identified on OCT. So again, the cardiologists who, as I'm sure Dr. Stark and Dr. Peterson and Dr. Yavagal can attest with all the radial stuff, they have so many patient volume. There's so much patient volume that they do all these clinical trials, and they tend to be ahead of us. They were kind of the drivers towards us starting, radial access. They also found that OCT has higher sensitivity for thrombus detection and plaque morphology when compared to, its older predecessor, intravascular ultrasound. It's better at identifying vessel dissections, intrastent tissue prolapse, incomplete stent apposition, and even neointimal hyperplasia following stent placement. So this is just an example of this in an image here. So A is an intravascular ultrasound image that demonstrates no obvious neointimal growth over the stent at 7-month follow-up. And that same vessel is then imaged with OCT, and you can see here that there is clearly some neointima over all of the struts circumferentially. So that kind of, segues us into our applications in endovascular neurosurgery. The first application of OCT in the extracranial internal carotid artery was reported in 2010, in which it was used to detect an intraluminal thrombus at the site of the plaque prior to stent deployment for symptomatic carotid stenosis. This ultimately changed management from carotid artery stenting to endarterectomy in this patient, and the pathology then confirmed a soft plaque with an associated with thrombus. So further studies have been performed to detect presence of intraluminal thrombus, neovascularization, stent geometry, and plaque coverage after carotid stenting. You can see here that image A demonstrates malapposition of the carotid stent after deployment here kind of in the 6 o'clock to 9 o'clock area where the arrows are pointing. And then B is an image demonstrating thrombus within the stent at about 9 o'clock here. So it's also been used in vivo in acute ischemic stroke. So this is just a paper that was published, I think, in JNS, where the group in Toronto used optical coherence tomography during mechanical thrombectomy for basilar artery occlusions. After thrombectomy, they found residual thrombus identified within the basilar artery in all of these patients who had total angiographic reperfusion. This is an interesting concept because it basically, shows that our understanding of what happens in thrombectomy or even in aneurysm treatment in terms of what happens intraluminally, we truly don't really understand because angiography, the resolution of angiography alone is relatively low because all of these patients had complete reperfusion with no significant evidence of restenosis following thrombectomy, yet the OCT demonstrated that there was clearly residual thrombi within the basilar artery itself. So the next step is talking about intracranial pathology and its uses there. So in 2005, the first animal study using OCT to evaluate aneurysm coiling was performed. And this demonstrated that OCT could identify fibrosis and endothelialization across the aneurysm neck that was not seen on angiography before. You can see here, this is just these cross-sectional views across the aneurysm neck following coil deployment with the OCT images below. You can see this endothelial layer that's being developed across the aneurysms at 7 and then 27 days. So subsequent studies have been performed to evaluate the safety and efficacy of OCT in the human intracranial vasculature. Technology has been able to identify every layer of the arterial wall, as well as small perforating vessels and stent struts in detail, not seen in angiography alone in humans. In 2015, the first case of in vivo OCT was used to guide therapy in the intracranial vasculature. So a patient was treated with balloon angioplasty and stent for vertebral basilar insufficiency. They underwent repeat angiography due to concerns for residual stenosis, and then subsequently underwent OCT, which demonstrated excellent stent apposition, minimal tissue prolapse through the stents, and minimal residual stenosis. So as a result, it kind of helped guide intervention and prevent this patient from going through an unnecessary repeat angioplasty or stenting. So we're now going to kind of shift our focus towards aneurysms and the application of OCT for these lesions, as this is kind of the crux of our work here at UM. I think the first step is to talk about kind of both the normal anatomy of our intracerebral arteries, as well as the proposed mechanisms for aneurysm formation. So cerebral arteries obviously consist of 3 layers. There's the intima with the basal membrane and endothelial cells. There's the media consisting of circumferentially oriented smooth muscle cells that are also embedded in dense collagen and elastin fibers. This is the layer that enables some compliance within the vessel. And then there's the adventitia, the outermost layer, which mainly consists of collagen and provides some structural integrity to the vessel wall. So importantly, the intima and media are separated by what's called the internal elastic lamina, which is believed to be kind of the key structure that needs to degenerate in order to lead to aneurysm formation on the structural level. Intracranial blood vessels are somewhat different than the rest of the body because of their thicker internal elastic lamina, their decreased proportion of elastin fibers and smooth muscle cells in the media, and then a thinner adventitia, obviously, because they're in the subarachnoid space. So this, together with their lower amount of connective tissue itself, makes these cerebral arteries more prone to develop aneurysms. So again, although the exact pathogenesis of cerebral aneurysm formation remains relatively poorly understood, extracellular matrix degeneration, hemodynamic stresses, and inflammatory responses have been suggested as kind of the key components to leading to structural fragility in the arterial wall. So the current hypotheses on cerebral aneurysm formation postulates the following mechanisms, basically. First, that there has to be apoptosis in the vascular smooth muscle cells within the vessel wall, and then some disruption of the internal elastic lamina. And then second, there's some collagen fiber reconstruction due to the resulting shift in tensile forces. This leads to subsequent collagen degradation and then vessel wall remodeling. So whether this remodeling will then result in aneurysm sac, either stabilization, progression, or rupture, is thought to be dependent on the degree of aneurysm wall inflammation, the hemodynamic stress on the wall, and then remodeling of the tissue and collagen within the wall. So the relevance of the inflammatory components in the pathogenesis of aneurysm progression and rupture is becoming increasingly more evident. This is just a good diagram that I found demonstrating the proposed mechanisms by which inflammation contributes to this aneurysm formation, progression, and rupture. So one here shows that there's this flow-related endothelial injury that occurs at an arterial branch point. This triggers an inflammatory response whereby it allows macrophages to infiltrate the arterial wall and then begin secreting pro-inflammatory cytokines. The mounting inflammatory response within the wall results in proteolytic destruction of the extracellular matrix and then smooth muscle cell phenotypic modulation. So macroscopically, that then leads to the arterial wall being remodeled into an aneurysm with progressive ballooning. So now that we know how aneurysms form, the question is, what can we do to combat such a phenomenon? This is kind of the question that we were trying to answer in Dr. Stark's lab, but I would be remiss if I didn't first talk about some of the newest treatment modalities for intracranial aneurysms, because it also is kind of one of the key points of the work that we're doing here. So I think it's important to discuss flow diversion technology, because this is kind of one of the most recent advances in endovascular neurosurgery that has really changed how we treat intracranial aneurysms. So in general, the idea of flow diversion is that the flow diverting stent is placed in the parent artery of the aneurysm across the aneurysm neck in an effort to both reduce flow into the aneurysm and then reconstruct the diseased vessel so that over time, the aneurysm is excluded from circulation. So I think this is a good diagram that really is helpful to understanding how flow diverting stents work. So after placement of the flow diverting stent, there's some alteration in the wall shear stress, usually a decrease in the wall shear stress, which then also in conjunction with reduction in mean aneurysmal velocity of the blood into the aneurysm dome itself, eventually leads to stasis within the aneurysm and then intraaneurysmal thrombosis. Concurrently, what happens is that it also provides a scaffold for endothelial cell growth. So through the stent itself, there's endothelialization along the device, and ultimately this leads to parent vessel reconstruction and aneurysmal occlusion from the circulation. So on a more cellular and molecular level, the proposed mechanisms underpinning flow diversion of cerebral aneurysms is as follows. They think that local endothelial cells that are activated by paracrine factors at the site of the flow diverter deployment use the device as a tissue scaffold and then recruit circulating endothelial progenitor cells to promote endothelialization across the stent and aneurysm neck over time. So I think, it's also important for us to understand the data that has driven the use of these devices. So the pipeline for uncoilable or failed aneurysms, or the PUFS trial, was one of the first prospective trials evaluating flow diverting stents for internal carotid artery aneurysms. 108 patients were with unruptured, large and giant wide neck aneurysms were enrolled in the study. The mean aneurysm size was 18 millimeters, so not small aneurysms. And then of the 108 patients, 78 had complete aneurysm occlusion and absence of major stenosis of the parent artery at 6 months. And only 6 patients in the cohort experienced a major ipsilateral stroke or neurologic death. So basically a complication rate of about 5%. So this, kind of what drove the initial use of flow diverting stents, because it offered a reasonably safe and effective treatment for large or giant intracranial internal carotid artery aneurysms with relatively high aneurysmal occlusion rates and low rates of complication. And these images here, I think, are just impressive and to just evaluate. These are the pre and post treatment angiograms of a giant left IC aneurysm in a patient who was presenting with an abducens palsy. You can see here, I think, in my mind, the most impressive image is the MRI. Pre and post at 6 months, and that this aneurysm, even the dome, has basically completely involuted. And the patient who presented with cranial neuropathies, at 6 months had the symptoms resolve. So a more recent study, and I think also, just as important, is the Premier trial. So this is a trial that was evaluating flow diversion for what we defined as small or medium-sized wide neck aneurysms. So these were aneurysms of the internal carotid artery or vertebral artery that were less than 12 millimeters but wide neck. They enrolled 141 patients, and at 1 year post-procedure, they had very similar results as a PUF trial, with about 76% occlusion without major parent vessel stenosis. And the combined morbidity and mortality of this cohort was even lower at 2.1%. So this study kind of confirmed that the treatment of even, wide-necked, small to medium-sized aneurysms with flow diverting stents still results in high rates of occlusion without significant parent vessel stenosis. So the reason why I bring both of these trials up is because, as you can tell, the follow-up demonstrated that about 76% in both cohorts had complete aneurysm occlusion. So although these obliteration rates were high, there's also a significant proportion of each cohort that did not have complete aneurysm obliteration. And this is just an angiogram here demonstrating this. It may be hard to understand if you haven't seen an angiogram before, but this is actually an ophthalmic artery aneurysm. And you can see that it's still filling. So this is after a flow diverting stent has been placed over the neck and it's at like 6-month follow-up. There's still some filling of contrast within the aneurysm dome layering within it. So the problem is that we don't have a good understanding of why this occurs. Why do these patients not have complete obliteration while other patients do? So some retrospective studies have tried to evaluate various cohorts and have identified some demographic predictors of incomplete obliteration, but the pathophysiologic mechanisms still remain poorly understood. Other studies have also demonstrated that if you have an arterial branch arising from the neck of the aneurysm itself, that this also reduces the rates of complete obliteration. And this kind of makes sense intuitively because there's continually increased flow demand near the neck of the aneurysm where to keep the adjacent artery patent. So this kind of brings me to the next step of the talk, which is the kind of future applications of this technology, both in terms of the flow diverting stents as well as OCT. So just last year, a recent study, it used OCT, angiography, and contrast enhanced CT in animal models implanted with flow diverting stents. And it found that OCT captured the presence of thrombus accumulation, incomplete device apposition in a more comprehensive fashion than both CT and angiography alone. So this image here you can see on the left just demonstrates an OCT 3-dimensional cutaway with malapposition of the flow diverting stent here indicated by the arrow, and then also multiple intraluminal clots over the surface of the flow diverting stent. B is a cross-sectional OCT image that then also shows a jailed arterial branch here. You can see marked by the asterisk, as well as multiple intraluminal thrombi on the flow diverting stent surface marked by these arrows. C demonstrates the proximal edge of the stent with incomplete apposition. You can see that the stent itself here at about 12 to 3 o'clock is not well opposed against the wall. D is kind of an endoscopic rendering down the barrel of the device itself, again demonstrating a jailed arterial branch point. As well as some intraluminal thrombi marked here by the arrows. And then again, E is this identification of side branches that are jailed within the stent itself, and then some intraluminal thrombi. So, obviously this technology has, I think, huge implications in the evaluation of flow diverting technology. You can see here, clots as small as almost 30 microns, as well as malapposition of the stent itself are captured by OCT, but aren't seen on angiography, right? So this is images in angiogram of an animal model stented with a flow diverter. The stented segment is indicated by the arrow here along the path of the artery. And then B kind of corresponds to the OCT images showing both, kind of thrombus formation as well as malapposition of the stent. You can see here in E and F that obviously is not seen on the angiogram. So this kind of begs the question then, are we missing some vessel stent interactions on angiography alone that is the contributing factor to these incomplete obliteration? Because it's hard to know. You can see the resolution here clearly is not enough for us to understand that there is in fact malapposition occurring or even intraluminal thrombi. So this kind of brings me to our current projects. So, I thought this was relatively fitting because, sometimes you just got to take a swing at it and sometimes it'll blow up in your face, but sometimes you also succeed. And even sometimes when it does blow up in your face, you may find some results that you didn't expect, but those sometimes can create some of the best research. So, as I stated previously, endothelial cell dysfunction has been highlighted as kind of one of the earliest events in cerebral aneurysm formation. And there's growing evidence that implicates inflammation as a key contributor to the pathophysiology of cerebral aneurysm progression and rupture. So furthermore, histologic examinations of both experimental and human aneurysms have suggested that the underlying cause of treatment failure is this incomplete reconstruction of the parent artery via lack of endothelial cell growth across the neck. And persistent inflammation within this incompletely obliterated aneurysm is what may contribute to this poor endothelial cell growth and then lead to further aneurysm progression and subsequent rupture. So here in Dr. Stark's lab, we've identified overexpression of inflammatory markers in aneurysm animal models compared to their parent arteries. And this image here is just a PCR analysis of IL-2 and IL-2 receptor beta that have significantly increased expression in rabbit aneurysm models when you compare them to the parent vessel. So, although drug-eluting stents were developed to combat a similar phenomenon in coronary artery disease, there remains no pharmacologic or bioactive compounds approved for the treatment of cerebral aneurysms. So here in Dr. Stark's lab, we developed a novel drug-eluting stent that, when deployed, directly delivers a controlled release of medications to the aneurysm neck to promote repair and repopulation of endothelial cells and decrease this inflammation, which hopefully will improve vascular healing and aneurysm obliteration. So these are kind of our preliminary results in our rabbit models. You can see here that this is the creation of an aneurysm prior to the deployment of a stent here. And our hope is that, as you can see here, that when compared to bare metal stents, that these drug-eluting stents have complete endothelialization and obliteration of these aneurysms. So again, A1 here just demonstrates the aneurysm prior stent placement. A2 kind of shows the stent placement with that red line. That's the inferior edge of the stent. And then A3 demonstrates this complete obliteration of the aneurysm at 30 days when compared to the bare metal stent here below, which shows that the aneurysm is still filling at 30 days.
I'm gonna build some stuff together and let's see what it is.
So the nanoporous structure of the stent kind of serves as a drug reservoir to provide sustained drug delivery over time. So we've demonstrated that sustained drug delivery over 1 month can occur with reduced neointimal hyperplasia compared to control, as well as decreased in-stent stenosis. However, as stated previously, there still remains no standard diagnostic tool to evaluate endothelialization across the aneurysm neck following treatment. With that in mind, we have been able to image these novel drug-eluting stents using OCT, demonstrating here appropriate stent apposition, as well as the ability to identify all three major layers of the arterial wall. So, as such, it was the focus of my grant to directly evaluate endothelial cell growth across the aneurysm necks using optical coherence tomography before and after the deployment of various stents. So our hypothesis was mainly that OCT is certainly more sensitive than angiography alone in detecting the degree of in-stent endothelialization as well as parent vessel interactions. So obviously, as lack of endothelialization across aneurysm necks has been associated with recurrence and incomplete obliteration of aneurysms, we need an imaging modality that can better evaluate the extent of endothelialization after treatment, because this may in turn identify early predictors of treatment failure. So again, we used rabbit elastase models with control aneurysms and bare metal stents in order to compare these drug-eluting stents via angiography, histology, and OCT imaging at 9, 18, and 30 days post-deployment. The differences between the angiographic and OCT images are then compared to the histology in order to determine sensitivity of OCT in detecting instant endothelialization and how that correlates to aneurysm obliteration. So we're evaluating endothelialization across the aneurysm neck, both quantitatively and qualitatively. So a quantitative analysis, we're evaluating the aneurysmal neck area that remains patent in order to calculate the degree of endothelialization compared to the initial baseline. And then qualitatively, as we previously have mentioned, the OCT has the capability of evaluating neointimal growth over the stent struts. So our qualitative evaluation of this is kind of dichotomized either into heterogeneous or homogeneous growth of the intima over the stent struts. This creates variations in back scattering patterns, and we're defining those as either, again, heterogeneous or homogeneous back scattering patterns. So our thought is that the degree and variability of endothelialization seen on OCT and histology will be compared to the presence or absence of aneurysm filling on angiography in an effort to determine the predictors of aneurysm occlusion. What we're hoping to find is that the continued presence of aneurysm filling after stent placement will be associated with a heterogeneous backscattering pattern on OCT, and that lack of aneurysm filling will be associated with low variation, which suggests that there's better endothelialization through the stent. And we'll confirm this also, obviously, with histology. So the current limitations of the technology, obviously, use of OCT in the cerebral vasculature requires light transmission and reflectance in a difficult environment. What that means is that the depth or penetration depth of OCT is relatively limited. It requires intraluminal blood clearance, which means that you have to flush the blood that's in the lumen prior to obtaining an OCT image. This leads to changes in intraluminal pressures. It's difficult in tortuous anatomy and creates diverse fluid dynamics that can inhibit that blood clearance and then also obscure the images. Prolonged flushing also obviously could disrupt various pathologies. As we all know, plaques, dissections, aneurysms are not necessarily diseases that remain stable with changes in intraluminal pressure. And then obviously tortuosity of the ICA has prevented ubiquitous usage. It's sometimes very difficult to navigate a stiff fiber into the internal carotid artery, which has kind of limited some of its uses in humans. And then I will say that although prolonged flushing was initially needed during the use of these devices early on, they've now created different techniques in which the images are processed so that there's faster acquisition time, which leads to decreased need for significant blood clearance. And then obviously, large aneurysm domes are still difficult to visualize because of the penetration depth of the imaging modality itself. So in summary, OCT has numerous applications in medicine. The ability to aid in the detection of tumor boundaries has the potential to change the field of surgical oncology. In neurosurgery, intravascular imaging of aneurysm neck morphology can provide us with a better understanding of why incomplete obliteration occurs. And if we can understand why certain aneurysms are at higher risk of incomplete occlusion, then we can further tailor treatments for these lesions. And in stroke, identification of vulnerable atherosclerotic plaques or residual intravascular thrombi has wide-ranging implications for the field. If we can recognize those patients who have residual intraluminal thrombi despite angiographic reperfusion, then we can potentially treat them more aggressively post-thrombectomy with medical management. So that kind of brings me to the end of the talk. Is there any questions that I can answer for anybody about the technology or anything like that? All right. Well, thanks everyone for listening. I appreciate it. I hope you guys have a good day.
Awesome work, Luther.
Evan, what do you foresee the future of this OCT and neuro-oncology? I know you've done your tumor fellowships. I'm just curious to see what.
Yeah, I mean, so there has been some limitations. I mean, I think it's been used previously to try to in real time identify changes in tissue tracts. So, obviously white matter tracts when you're resecting gliomas, they've attempted to do it, but it hasn't worked well because of the difficulty in in understanding that those changes in the white matter tracts and how that's applied to the DTI, if that makes sense. But they're trying to do that. I mean, I think the first step in my mind is kind of what we talked about, where it can help identify tissue boundaries. So if there's a, if potentially like in low grade gliomas where there may be a better tissue boundary, it may be able to identify true differences from, when you're, transitioning from low grade to normal brain. I think that's kind of where I foresee the first step happening, because we were already able to do that intraoperatively with like lymph nodes.
And this would be like a handheld device?
Yeah, exactly. It's on a handheld device. I mean, I think previously they tried to use it on the end of a microscope, and I think that's where the limitations were as well. It's kind of it's difficult to have it on the microscope and then image the surface and then try to update that with the DTI. I think I'm trying to remember the group, but I think they did it at Henry Ford, to be honest with you, a couple of years ago. When in their efforts to use DTI during resections. But I think the first step is that I think it will help us determine tissue boundaries first. If we can use that in a handheld device, which is what they use for these lymph node dissections, it's a little handheld laser fiber. Then I think that's the first step. And then after that, it can be applied to other things like white tract deformation during surgery.
Thank you.
All right. Thanks, everybody.